Oh, one of my favorites. What is this? This is so fun.
I can take this one. It's you can see that there's like adipose tissue here, but it's really small. It almost looks like, at least to me, like it's hypercellular because
Yeah,
it's darker than you would expect. So
absolutely.
this is lipoatrophy.
Very good. Lipoatrophy or fat atrophy, and this is a like very extreme example. I see this pretty commonly in much more subtle, nuanced amounts on a pretty regular basis. To see it like this is uncommon. But I like what you said that there's fat there. Once you realize it's fat, at first glance you might not realize that this stuff is fat, right? It doesn't look like normal fat at all, and it's way more cellular. But when you go closer, you're like, what are all these little round vacuoles? They look like little tiny baby fat cells. If you're having a really bad day, you could potentially think that some of these little round cells look like signet ring cells, like you can see in some forms of adenocarcinoma, like gastric signet ring cell, gastric adenocarcinoma, or other places can in the body can produce signet ring morphology to their adenocarcinoma. So I know here, like this looks like fat, but I think you can see how like some of these, and they almost look like they're making infiltrative single file cords and chains, like some carcinomas grow. I've certainly seen cases that really could cause confusion and mimicry of a signet ring adenocarcinoma, which is something that probably you don't probably see very much in dermpath. I know I don't see it in dermpath, and it's probably not in a lot of study sets. But for pathologists, I think it's a really important pitfall to know about that those cells are not carcinoma. Easy to sort this out. Just do a keratin. Keratin will be negative here, okay? But the other thing from lower power, Nick, like you said, the really helpful thing here is the fat. It looks cellular, but you can still see that it's in lobules, right? There's one lobule, two lobules. Here's another lobule. So remember, normal subcutaneous fat or fat anywhere is arranged in lobules that have like delicate fibrous septa in between and kind of the bigger vessels in the septa. And then as you get out into the middle of the lobules, you have little tiny vessels. These little tiny vessels, look how many. There's tons of little tiny vessels. In fact, for anyone who has seen a myxoid liposarcoma before, the little tiny chicken wire vessels of myxoid liposarcoma, which is vanishingly rare in the skin, is usually in deep soft tissue, so kind of outside the scope of what we're talking about. But the vessels in that tumor look a lot like these vessels, and that's because that tumor is recapitulating embryonic fat, and these kind of vessels are always present in fat. The reason you can see them here is because as the fat cells shrink and the lipid gets used up and goes away, the cells get smaller, which means the nuclei that are always there get closer together and more dense. There are more nuclei in a given area of space on the slide. Same thing with the vessels. The vessels that are always there to transport lipid in and out of the adipocytes for fat storage and fat release when we need it for energy, right? That's why the fat is very richly vascularized, but they're really tiny vessels, right? So those vessels, though, as the fat cells shrink, more and more of the vessels get closer together and you can see more of them. So fat always has this amount of vascularity and cellularity. It's just way more, or I guess let me say, these cells are always there in fat. They're just all closer together when there's not all that big white space pushing them apart. So that's what results in this unusual appearance. The reason that's important is because, like I said, it could mimic carcinoma. It could mimic a liposarcoma if you're having a bad day. It could just cause you confusion as to what the heck is going on here. So why does lipoatrophy happen? What are some causes of lipoatrophy, fat atrophy?
Steroid injections.
Yeah, definitely. If you inject steroid too deep, too much, too strong down into the subcutis, it can certainly shrink and atrophy the fat. That's true. Anything else? Look at this artery in the meantime with that nice internal elastic lamina. I just noticed it and I thought it was pretty. And hey, while I'm gonna show you something. Can you guys see this funny, weird, like geometric pattern in the background, or am I like hallucinating that? Maybe it doesn't come through because it's too small. Okay, maybe it's hallucination also. I'm not sure. I got a new computer, and now when I zoom in real high power, I can see this like meshwork of geometric lines that are like weird pixels that I assume is something with the way my graphics card is displaying this. But it's so bizarre because I'd never seen that before. And then I saw it and I thought, oh, it's a weird scan. Then every slide looked that way, and I was like, it must be something with the way my new computer is displaying. I just have never noticed that before. I promise it's real. You guys can come to my office and see in person. But anyway, sorry for the diversion. I just noticed it again and I thought it was wild. Okay, so other lipoatrophy things. So yeah, definitely steroid injection, trauma, right? Pressure from an adjacent mass. I see fat atrophy and muscle atrophy sometimes next to tumors, like big soft tissue tumors that push and compress the fat. You can also get it from starvation or severe malnutrition, right? And those cases are really impressive, but thankfully we don't see them as often. But basically, the body just uses up all the fat and the cells are just like left as little husks, without their lipid inside. I don't know what the story was in this case as to why the atrophy happened, but a pretty good impressive example. And particularly like for pathologists watching in the GI tract, if you see this in like the omentum or some of the fat around the GI tract, it certainly can really make you think more of like a signet ring carcinoma. So don't be afraid to use a keratin if you got any doubt. And no, there are a variety of like lipoatrophy syndromes and diseases, all of which I found really boring and hard. Not that they're not important diseases, but really hard to read about. And when I was in training, because they're like no special pathology findings, they're just all yes, there's atrophic fat, but they all have like hemiatrophy or other. I don't even remember the names. There's so many of them. In advanced AIDS, I think you can get lipoatrophy. So all sorts of different things. But anyway, this pattern can be applied across that. And oftentimes too, I will see some degree of fat atrophy in association with fat necrosis. Okay, so in traumatic fat necrosis or lipodermatosclerosis, oftentimes you will have some atrophic fat mixed in with the necrotic fat. Cool. Oh, and one more vessel, cute little incidental finding. Look at that. This is a little, probably thin-walled vein, although maybe it could be a lymphatic. I cannot reliably tell them apart. But either way, it's a valve. See? You can't like sometimes you can perfectly see the opening between the two leaflets, but that's a valve either in a small venule or lymphatic channel. It actually does look like a lymphatic there, but I thought for sure that I knew something was lymphatic or not before, and then stained it with D240. And I found that my ability to predict it reliably is not super high. So even though I'm a soft tissue pathologist too that has interest in vessels, I can't always tell lymphatics from tiny veins. Okay, questions? Next case then.